Next, I'd like to introduce Adam Handel, who is the head of the Oxford Autoimmune Neurology Group and also undertakes clinics as a neurologist, seeing patients with a range of neuroinflammatory diseases. Now, we recently had Adam visit us in Edinburgh, and we made him speak to a very large number of neurologists in a very tiny room, so it's delightful to introduce him somewhere more appropriate. So thank you.
Well, thank you so much for the invitation to speak, and it means a lot to speak, particularly on a day when Angela Vincent's contributions to the field are being properly recognised, because everything I'm going to show you today essentially relies on her foundational work. So I think that's important context to remember. So I've got a bit of an easier job than Belinda had. I'm going to go at it from the other direction, thinking about patients who have a relatively clear diagnosis of autoimmune encephalitis and thinking about what psychiatric features you might see in those. And I'm going to show a little bit of our data and some data from other groups as well. First of all, I'll just give a very quick overview of autoimmune encephalitis, and then I'm going to move on through the two commonest forms of encephalitis where we have a known antibody. And then finally, I'm going to think about a few more controversial features with rarer autoimmune encephalitides and also perhaps patients where we don't yet have an antibody that we think might be causative. So this is just to go through some epidemiology. So we all know that it's pretty rare. This was from a capture-recapture population study a while ago, so it's about 5 per 100,000 per year. And the traditional view, which I think most people are coming away from now, is that autoimmune encephalitis was by far the rarer sibling of infectious encephalitis, but that's not actually true. The two are probably about equal now. And you can see that here. If we look at a population study that was performed in the US, another thing that's worth bearing in mind is that even though we think about antibodies that we can identify being critical for the diagnosis, there are actually a group of patients who have clear limbic encephalitis or other forms of autoimmune encephalitis that do not have antibodies detectable. And actually, if you group these together, it's probably about a third of patients in total, if you disregard the ADEM, that behave a bit differently. But there are very useful clues, and I suppose we can think about this maybe in the context of the cases that we saw, the very interesting cases presented earlier, whereby thinking about a few basic demographic features can really inform your prior probability of what antibody people might have. So if we think about the two commonest ones, so NMDA receptor antibody, as we all know, is basically a disease of young women, whereas LGI1 antibody encephalitis, which is the other commonest one, is essentially a disease of older men in general. And that can be a really useful way of thinking about how we would rationalize antibody testing in these sort of cohorts. But having clinical suspicion is clearly a key aspect of this, and that's particularly true when we start to go towards the grayer cases where there's perhaps more psychiatric manifestations, maybe fewer hard or indeed soft neurological signs or symptoms to inform you. And these, you'll have seen a sort of version of this before, but these are the Grouse criteria for diagnosing possible autoimmune encephalitis. And this is certainly something that's really useful to have in your mind when you see these patients, because it gives you an idea of whether testing would be appropriate here. And you can see that essentially you've got a set of clear criteria set out. And the key, I suppose, particularly when we think about those cases and other cases where you might suspect this, is the subacute onset. So generally these are quite brisk in onset, and that can be features of cognitive or behavioral or psychiatric decline, along with some sort of supportive or suspicious abnormality, including focal neurology, seizures, or some paraclinical information that might give you possible idea. And of course, as all of these diagnostic criteria have, you need to exclude other potential criteria as well. There are some features that don't necessarily appear on this slide, but are essentially pathognomonic, and we'll see one of them later, but you'll have all seen patients most likely with fatiobrachial dystonic seizures. And actually, when you see these, it's a really helpful sign, probably more helpful than any other paraclinical information, because there's pretty much nothing else that will mimic this. And actually, going back to Belinda's points, actually, perhaps in some ways these grouse criteria may be too restrictive in certain patient groups, because there was a recent series from the US published which suggested actually even in patients that didn't formally meet these criteria but had suggestive features of an autoimmune encephalitis, a proportion of those were immunotherapy responsive as well. So if we just think through NMDA receptor antibody encephalitis here, we saw some of this earlier actually, but this is the data again from Sarosh Irani's early brain paper in a cohort of these patients. And I think the main thing that is worth emphasizing here is the rapidity by which they move through a stereotyped clinical phenotype, going from, as Belinda said, an early psychiatric manifestation, but then often developing in these classical encephalitis patients other features such as seizures, hypersomnia, and going on to develop these sort of more subcortical features of movement disorders, autonomic dysfunction, gaze paresis, and so forth. But it's worth, I think, thinking a little bit about the immunotherapy of the immunopathogenesis of these conditions as well. And as Belinda said, it's astonishing when you see patients with these teratoma-associated NMDA receptor antibody patients, which makes up about a third of the total patient group, because taking teratomas out is really absolutely transformative, and the symptoms will often just melt away, whereas before they may have been given rounds and rounds of immunotherapy and been very, very treatment resistant. And you can see here from a few papers from a few years ago now that actually we've started to understand the underlying immunopathogenesis associated with these ovarian teratomas. So if you look here, this is the classical appearance of the ovarian teratoma removed from one of these patients. And what you can see is that there are both T cells and B cells associated with high levels of NR1, which is the NMDA receptor antibody subunit against which the antibodies react. And within this group, you can see antibody-producing cells. So this would fit with a lymphoid follicular structure, and therefore you might well think, and we do, that this, in that third of patients who have ovarian teratomas, is likely the first place in which the B cells, the autoreactive B cells, meet their cognate antigen. And this is supported, actually, when you look at the sort of levels of antibodies you get in different compartments. So, for example, if you look at peripheral blood here, serum, and the tumour aspirate, you can immediately see that the fluid around these teratomas have much higher levels of NMDA receptor antibodies than exist in the peripheral blood, suggesting that there are B cells within this structure actively producing autoantibodies. Okay, so we've seen some of the psychopathology of this condition already, and obviously, as a neurologist, I wouldn't sort of dare to put too much weight on my own judgment. So therefore, I defer to an excellent colleague who's an academic psychiatrist in Oxford as well, and you'll have seen this plot already from the earlier excellent talk. But essentially, this shows the different large categories of psychopathology into which NMDA receptor antibody encephalitis patients fall. And you can immediately see from these bars that the thing that stands out is that these patients have multiple different psychiatric manifestations all at the same time. And that's shown again in this Venn diagram here, where if you separate out into different categories, many of the patients sit within the middle of this plot, suggesting that they've taken from multiple different areas that would normally be separate in different patients. And again, that was supported by the idea that really to capture the variance within this data set, you need a large number of low-level psychopathology categories to do this. But we can go on and look at this a little more. So if you think about individual conventional primary psychiatric diagnoses, many people have tried to categorize NMDA receptor antibody encephalitis into one of these, but we showed that actually often there's this spanning of diagnostic categories within the same patient, and that was shown here in a sort of informational plot where actually you need more diagnoses, 2 primary diagnoses, in order to really categorize all of the psychopathology you see in these patients. And one of the other really important things that came out of this paper was it was only the interaction between neurology and psychiatry that led to accurate psychopathology descriptions in these patients. And that was shown in the subset of case series where psychiatrists interacted with neurologists. So I think that really supports Belinda's point and other points others have made about interactions between neurologists and psychiatrists being really critical. Similarly to the psychopathology, you can look out for clues in the sort of harder neurological signs. And this was work from a little while ago, essentially showing that just like with the psychopathology, many of these patients do not fit within a primary neurological movement disorder category either. The majority of them require 2 of these movement disorder descriptions to describe, and about half require 3. So it's a very distinct and unusual movement disorder if you see it, which can again help with diagnosis, particularly in uncertain cases. So I'm going to move on now to a different antibody-mediated condition, and lots of this work actually has been conducted by Sophie Binks, who's an excellent academic neurologist within Oxford. And actually this has just been accepted, so you can scrub that out and put accepted instead. So this is a brief case study just showing some of the psychopathology that you can see in these. So this is a 67-year-old ex-accountant, male, who didn't have any background history of physical or psychiatric disorders, but had presented with a few months of sort of insidious personality change with aggressive verbal outbursts and just occasionally reduced responsiveness where he wouldn't talk to people around him, just lasting a few seconds. And he'd also developed these rather unusual habits here where he would count paper clips compulsively, he would hoard unusual objects around his house. And around this time also his sleep and self-care deteriorated. And it had been noticed that he was getting these recurrent episodes of left hand jerking with facial contortions. And you can all see where this is going now. And actually, he had an extremely active GP who somehow managed to get an MRI brain scan for him, which is phenomenal, really. But it was normal. And he had some blood tests, probably not the critical one that you're all thinking about, but that was normal as well. So he was treated with olanzapine for presumed mania, but actually just got worse. And he was having, he thought people were around his house. He was seeing cats coming out of the walls and having parties in his house. He thought the pictures were talking to him. And he started either going out of the house dressed as a pirate or naked. I think the pirate's probably preferable, isn't it? But anyway, he was then, 14 months after the onset of his symptoms, admitted to a psychiatric hospital, where the inpatient team very astutely noticed these ongoing left jerks, which have been going on now for over a year, and referred to their neurological colleagues, who then tested his LGI1 antibodies and found these were positive. And actually, on repeating the MRI scan, you can now nicely see that he's got the classical appearances of increased signal on flare imaging in the appropriate area of the mesial temporal lobes. He was given IV methylprednisolone with a pred taper, relapsed later, but actually, and this is quite important, that often these sort of relapses in patients who've been treated with steroids are put down to steroid-induced psychosis, but actually you need to be really aware that often this can be a resurgence of disease activity instead. So in this case, he was treated with aripiprazole, put up on increased steroids and recovered quite well. So, just thinking about LGI1 antibody encephalitis briefly. So you've seen some of the typical changes on MRI already, but Sophie and others described this really nice life trajectory, which looks a little bit like the one Ruth put up for MS earlier, although much less well understood. So clearly it's disease of male gender, and there's a very, very strong HLA link. So about 95% of these patients will have HLA-DR7. We think there's probably some midlife events that put you at risk, but really they're not understood at all, really. And then you have a relatively short prodrome where you'll develop, as this patient did here, some faciobrachial dystonic seizures, which we'll see in a second, potentially other seizures with amnesia and personality change. That will then build up into a frank encephalitis, which is when you might start to see the behavioural and psychotic changes, which are of most relevance to this talk today. And then with treatment, you recover to some extent, but are often left with long-term post-encephalitic syndromes, which is very problematic. And importantly, paraclinical testing isn't always reliable, as you saw here. So the MRI is abnormal in most, but as you saw, can have a dynamic evolution. They often have hyponatremia due to hypothalamic involvement. And the EEG, which is often very useful in things like NMDA receptor antibody encephalitis, is much less useful here, as it's only abnormal in about a third. And similarly, CSF, which again is very useful in NMDA, is much less useful here. So here you would see a video. I don't know if I can, nope. But you all know what the fatiobrachial dystonic seizures look like, and if you don't, then you can always look it up. So there we go. The reason that it's really, really important to see these pathognomonic signs is we've known for some years now that the earlier you start immunotherapy, the more likely you are to be able to turn off these fatiobrachial dystonic seizures. And actually that's important for more than just seizure control, because if you look at your risk of developing cognitive impairment, this is very strongly linked to whether you're having active fatiobrachial dystonic seizures going on or not. So you can see here, if you can switch off someone's fatiobrachial dystonic seizures before they become cognitively impaired, they pretty much have no risk of developing cognitive impairment, whereas they continue to have increasing risk as fatiobrachial dystonic seizures go on. Just coming back again to a little break for some immunopathogenesis, we've done some recent work looking at what the B cells within the CSF might be doing here, because we know actually that the antibody is more sensitive in the peripheral blood, but we wanted to see whether there were LGI1 specific B cells here. So we did a lumbar puncture, sorted and did some single cell sequencing, and we could then clone these antibody sequences into hex cells to produce this and test those on brain, the cell-based assay that you saw Belinda talk about earlier, and live neurons. And you can see some lovely pictures here looking at LGI1 and Caspar-2. We had one Caspar-2 patient in here as well, showing a positive co-localization between antibodies and the Caspar-2 transfection, likewise for the LGI1, and actually that these monoclonal antibodies and serum could also light up live neurons and show characteristic staining patterns on immunohistochemistry. But what was really interesting is that when we looked at these individual B cells within the CSF compartment, we could see that many of these B cells were clonally related, so they had the same immunoglobulin sequence and they'd expanded up. And interestingly, when you then look at how many B cells formulate one of these little clonal clusters here, if you get 4 or more identical B cells with identical immunoglobulin sequences, they were all reactive to LGI1 or Caspar-2, depending on the patient population. And then if you go down to either smaller clonal groups or singlets, it reduces down. So that suggests that there's sort of active B cell production of autoantibodies within the CSF compartment that's supporting the disease pathogenesis. We also looked at the clonality of the T cells within the CSF, and actually, unlike the B cells, we didn't find that these were clonally expanded, which we suspect means that the follicular reaction, so the lymphoid follicular structures, are peripherally found, which would fit with the idea that you have more LGI1 antibody peripherally than centrally. Okay, but obviously psychiatric problems with these sort of conditions, and we're thinking about LGI1 antibody encephalitis here particularly, are not just found, as you all know, acutely. Although we think of these as very treatable conditions, actually when you look at this cohort who have been treated with immunotherapy, often quite effectively, about 85% will still show, unfortunately, some degree of abnormality. And many of these things are driven by neuropsychiatric symptoms such as depression, anxiety, also fatigue as well is a huge problem, as well as the things that you might more predict, such as memory problems and some problems on the frontal assessment battery as well. And here you can see that these post-encephalitic problems fall into distinct clusters. So you've got a very neuropsychiatrically enriched cluster here, so with lots of anxiety and depression and so forth. You've got a quality of life cluster here, and then a cognitive cluster here. What's perhaps interesting is that disability, which we would classically think in these conditions would come more from cognitive problems, actually associates really strongly with your remaining psychiatric symptoms as well. So that probably suggests that there's unmet need here that we're not currently addressing properly. But obviously, going beyond the two most common diseases where we know what the antibody is, there are many others that have psychiatric manifestations. And there's a nice review paper here which goes over all of them. But I've picked out a few main ones that I thought might be worth thinking about, as these are often quite informative in thinking about clinical cases and so forth. So one characteristic thing, a sort of sleep dysfunction, and I'll show you a little bit of that in a minute. But many of these are linked to mood dysfunction acutely and chronically as well. And then finally, we've already seen the importance of thinking about catatonia. And as well as NMDA receptor, there's also descriptions in GABA-A receptor antibody encephalitis. So I'm now going to focus a little bit on these two just to finish off in the last few minutes. So if we think about IGLON5 antibody disease, it's pretty rare. Much rarer than the other NMDA receptor antibody and LGI1 antibodies that we think about. It's again a disease generally of older age, and often it presents with this characteristic combination of a bulbar syndrome, so problems swallowing and often some characteristic breathing problems, a hyperkinetic movement disorder, so they often have a choreoathetoid movement disorder, and a sleep disorder. But actually, as well as that, there's a minority of patients who present with psychosis as well. So that's about 17%. And actually, the characteristic sleep disorder is quite useful to look for. And it's a little bit different from what you would see in things like dementia with Lewy bodies, because it actually intrudes into all aspects of sleep, and also is often associated with a stridorous breathing overnight. So that can be quite a useful clue. And it's not as strongly linked to an HLA as LGI1 antibody encephalitis is, but certainly over half of these patients have this extended class 2 HLA found. And you can here see some useful sort of radial plots of the different symptoms that they have. And this is highlighting that there seem to be differences in the symptomatology when presenting either subacutely or with a more insidious, slowly progressive disease. And perhaps for this talk, I would like to highlight that with IGLON5 antibody disease, the ones with psychosis and hallucinations tend to be those with a subacute brisk presentation. Again, if we think a little bit about the immunopathogenesis of this, there's several different cells and locations that have been identified. So you can see some perivascular sort of B cells here and some parenchymal T cells here, suggesting that actually the location within the brain where the pathology happens is a bit different if you think about different aspects of the immune system here. And then if you look at areas of activated T cells where they're producing granzyme B, which is associated with neuronal toxicity and so forth, that actually happens both within the perivascular spaces and the parenchymal spaces. And this is really important to think about because IGLON5 antibodies are predominantly IgG4. So we can look at the areas of the brain where this deposits. And sorry, that doesn't project terribly well. But anyway, so here you can see some, so this is looking at a brainstem slice here, and you can see that there's rich IgG4 deposits within the brainstem, but also within parts of the cerebellum and within the hippocampus as well. And here you can see a beautiful image just showing that the IGLON5 antibodies co-localize with an IgG4 specific antibody. And actually, this study was really pivotal in suggesting that the IGLON5 antibody deposition precedes a tauopathy. And we know that in this condition, once you've had the antibody deposited, you then get a tauopathy spreading across the brain thereafter. And the idea of the immune process preceding the sort of more progressive neurodegeneration aspect of the disease fits again with measures that you might use to inform your treatment decision in these patients. So here they were looking at neurofilament light chain prior to the administration of immune therapy. And you can see here that if you've got a raised level of neurofilament light chain, your chance of dying is very, very high, actually. And that's, again, seems to be feeding into how quickly these patients are treated. So here you can see in blue the ones that were treated within a year, and in red the ones that had a much longer treatment delay. So it seems potentially that if you can switch off this process early, you may be able to prevent them continuing into the more irreversible neurodegenerative aspect of the disease. And that can be quite useful clinically. Okay, so if we come on to the sort of last known antibody-associated disease that I was going to talk about. So this is GABA-A receptor antibody encephalitis. And it should be indicated, as with IGLON5, that it's really very, very rare. So, you know, your prior probability of seeing this amongst a patient group is quite low, actually. And often, in the classical encephalitis presentation, these will be very seizure predominant, about a third presenting with status epilepticus. And they also have these classical MRI changes here, where you can see a mixture of cortical and subcortical multifocal changes. But also they will have, in a significant proportion, very prominent psychiatric features as well, including catatonia, hallucinations, depression, anxiety, and behavioural change. In addition, intriguingly, about 18% will have a thymoma underlying this as well. And the mechanistic aspects by which this causes disease is not fully understood, but we can speculate a little bit. And so if I can just remind you of your medical school immunology, if you may have forgotten it. So this is a cutaway section of the thymus, and there's two main areas that are of interest here, the cortex and the medulla. So you're developing T cells come in here, interact with cortical thymic epithelial cells, and these are very specialist stromal cells that express a vast proportion of the proteins within the body. And essentially, these are trying to decide if the T cells are worth letting through, if they do anything or not. And then classically, they go on into the medulla, where they can be directed into different lineages. So if they meet this cell here, which is expressing lots of self-antigen, and they interact strongly with it, then they'll be killed off because they're autoreactive T cells. If they have a sort of intermediate activity, they might be let out as T regulatory cells. And if they have a weak interaction, then it's assumed they're non-autoreactive, so they can escape. But actually, if you look at single-cell sequencing data from these medullary thymic epithelial cells here, which are mediating a lot of the selection of these developing T cells, and then you look for the GABA-A gene, it's actually expressed in almost no medullary thymic epithelial cells. So that may potentially link these thymic pathologies to why you end up producing GABA-A receptor antibodies. But finally, as I said before, there are a group of patients, a significant group, who do not have antibodies found despite our best efforts to hunt. And then you rely on more this sort of antibody-negative but probable autoimmune encephalitis criteria here. And you can see that many of the same things exist here as we saw in the earlier possible autoimmune encephalitis criteria. But it requires many more paraclinical demonstrations of neuroinflammatory disease. And many of these patients won't make it to brain biopsy, so you may be relying on both an MRI abnormality and a CSF pleocytosis, which may be quite a strong level of evidence if you think about not all of the antibody-mediated patients meeting those stringent criteria. But again, for the focus of this talk, you can see that a large proportion of these different patients, and you don't need to worry about the exact terminology here, they're just subsets of seronegative autoimmune encephalitides, but a large proportion, about 3/4, will have prominent psychiatric symptoms as well. Although, unlike many of the other conditions, such as NMDA receptor antibody encephalitis, these have been much less well described so far. So, just to finish off, hopefully I've shown you that there's lots of different autoimmune encephalitides, which have prominent psychiatric comorbidities and symptoms associated with them, both at the onset, during, and after the time that you've treated them. I think we've made good strides in understanding the immunopathogenesis of some of these conditions, but actually linking these to the specific psychiatric manifestations, and indeed the heterogeneous presentations within this patient cohort, I think is still a work in progress. And hopefully, I think I've shown that the collaboration between neurology and psychiatry is really key to understanding and treating these conditions. So thanks very much for your attention. These are just a small subset of the people that I need to thank, particularly Sarosha Rani, who's now gone off to wrestle alligators in Florida. And I always thank my family as well, who've put up with me for quite a long time. And thank you very much for listening.